Thank you. So I'll just do a quick, overview of the structure function correlation in octopus data. And Dr. Sachin and most of the other speakers have made it very easy for me. I do have financial. So what I'll do is I'll just do a case-based correlation of the data of how I use it in my clinic, early diagnosis using SAP imaging and overlapping disease when you have cataract and glaucoma, and then how do we manage the follow-up and the challenges and the actual compliance. Now, basically the diagnosis, as you know, we have a structure and function correlation. Now, when you have a software which can also extrapolate the visual function structurally, for example, like Dr. Sachin was saying, when you have something like this, and then it is extrapolated this way, it is so easy to also show it. One moment. It's one moment, please, because this thing is obstructing my slides. Okay, so you can see the correlation very well. So what happens is the polar analysis actually tells you where to see the optic disc when you're in a busy clinic. So I'll just give a couple of examples which will make it more evident. And like I said, the perimetric changes are logarithmic and structural changes are linear. So you'll always have the difference in that. So this is a 47-year-old female, and this is a 7-in-1 printout. Traditionally, we are used to seeing a 7-in-1 printout. Like Dr. Sachin said, I would always use a 9-in-1 because it also gives me the sector MDs. It's the sector mean defect or mean deviation values. Because when you average an index into a single number, it gets wiped out. But when you go sector-wise, it tells you that one sector is highlighted, and you can also see that there is something happening here. So this patient typically underwent actual clinical examination, and we found there was a small little heme. So next day she came back for a visual field, and sure enough, there was some amount of depression in these areas. So the sensitivities were decreased. So the moment you have the sensitivity which is decreased, which is correlating with something like a hemorrhage on the disc, then you know that you are dealing with pathology. So what you do is you go ahead and then analyze it. And when you look at the corrected probabilities, it is showing that 5% of the population, this is normal. So which means it is actually abnormal in 95. So what it tells you is it does not give you the diagnosis, but it tells you that the sensitivity is less. And it's for you to clinically correlate that data. So when you look at the MDs, if you have this reduced to a single number, this will never highlight. So what it does is it gives you this particular area which correlates with the defect which is there. So when you analyze it, you look at this small little bar, and this gray area is the normative area. Then this is 10 decibels, 20, and this is 30. So the length actually tells you what is the depth of the defect, and that correlates very well with the hemorrhage. And when I did a OCT, you must remember that is not gold standard either. So it just measures a fixed diameter, and that fixed diameter does not coincide, and actually it is green. So I basically have a green disease, and it's a basic, when we look at glaucoma, it's the inner retinal layers which are affected. So the axons have not yet, the Wallerian degeneration has not yet reached the optic nerves. But when you look at the macular map, you can see that definitely there is a loss. And in the left eye, you can see that, it's almost normal. So this is basically a focal defect with green disease. So summarizing this case, I used a 9-in-1 printout, which highlighted what I had to see immediately. So the corrected cluster analysis, the polar analysis displayed the early defect. So isotope representation and fundus picture correlated. And then, of course, the OCT does show a green disease, but then the macular map tells me that there is something going on. So this highlights the need for a good clinical examination along with perimetry, and understand your perimetry very well and where you're deploying it and how you're using it. And this is a second case with overlapping conditions. The 71-year-old male presented defective vision. His IOP was 24. So there is a lot of media haze. Of course, now you have fundus camera like the IDEN, where even if there's a media haze, you can see what's going on. But on careful analysis, there is something going on here. So that this is the left eye and right eye. I like to put the left and right because it's easy to kind of correlate when you're looking at visual fields. And this is the 9-in-1 printout, and you know that something is happening in the nasal fields. And when you look at the polar analysis, which gives you the structural extrapolation, you know that where to look for in the optic disc. And this is called the 2-on-1 printout. So the 2-on-1 printout, and remember, this particular grayscale is derived from the comparisons, meaning that you have the raw values which is indexed to age. So when the raw values are indexed to age, and when you have this, you remove all the unnecessary clutter and you look at the topography of the defect. So when we do a visual field, we are looking at the topography of the defect, and it's not that this many points, this much percentage. We look at what is the topography of the defect. Is that correlating with the structural defect? That's what we're looking at. And this is, of course, the Bebby curve, which tells you that the diffuse defect is here, and you have the focal defects, which are the slope, which is the SLV, which is the same as PSD. And then, of course, across the median graphic, you find that there are some high values across this, which correlate in the actual corrected probability. Corrected probability corrects for age as well as the diffuse defect, and it highlights the focal defects. And this is on the nasal side. So you do have a left to right printout. You can easily, this is where your nose is. So it's very easy for you in a busy clinic not to miss these things. So you have a 9-in-1 printout, you can home on to what you're going to see. And sure enough, you have the actual polar defects, and which coincide very well. Now, this is just Photoshop. This is not the way it is there in the software, but this is where it kind of coincides. So ISUT actually extrapolates the functional analysis as a structural representation. And this is, of course, the OCT, which definitely highlights that. We don't need really OCT to tell that, but we can do that with a good clinical examination as well. Okay.
Thank you so much, Dr. Rengaraj.
Thank you.
And in a short notice, again, you could manage to show everything possible.
Much.
And I think you have covered my talk as well to an extent. Thank you so much for that as well.
Yes, I will just stop sharing.
Dr. Rengaraj is one of the authors for the Octopus Visual Field Perimetry guidebook. It is one of the wonderful books I think people should read on visual fields. So